All right, we are at the top of the hour. So hello and welcome everyone to another MMS info session. As you know by now, these sessions are offered under the CMS Measures Management System contract, which is held by Battelle. I'm Brenna Rabel. I oversee education and outreach on this project. But today's session is all about registry, so specifically qualified registries and QCDRs and the role that they play in the MIPS program. You're going to be hearing from members of the PIMMS team, specifically Sharday Buchanan from CMS, Hector Cariello and Marla Throckmorton from the Lantana Consulting Group, as well as Jocelyn Meyer from GDIT. Next slide, please. So these info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. And that's an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and of course, routine updates to the Measures Management System website. As we've been telling you over the last few months, we are so happy to report that we are resuming doing these info sessions on a monthly basis so that we can continue to provide up-to-date information on a wide range of topics related to quality measure development. But before we jump in today, I just want to cover a handful of housekeeping items. The first is that today's session is being recorded. The second is that all participants are going to be muted throughout the call. We are going to have an opportunity for Q&A at the end, during which we would encourage you to enter your questions into the chat feature, and we'll get to them as long as time allows. And then finally, the presentation slides from today's session have been posted or will be posted to the MMS website for your reference. They'll be updated in a week or so with notes from today's session, and then we'll also be posting a recording of the presentation to the CMS YouTube page at a later date. Next slide. All right, and just really quickly, I wanted to kind of highlight some of the goals for today's presentation. We're mostly hoping to shed some light on this particular aspect of the MIPS program, and by the end, hoping that you'll be able to understand what third-party intermediaries are and understand some of the key differences between a qualified clinical data registry and a qualified registry. Our presenters are also going to explain how QCDRs can report measures and how CMS evaluates measures proposed by QCDRs. Next slide. With that, I'd like to turn it over to Sharday Buchanan to talk us through some of the specifics of today's presentation.
Thank you. So as Brenna stated, I'm Sharday Buchanan. I am the co-lead at CMS along with Dr. Daniel Green. Unfortunately, he has another meeting, so he's unable to attend. But I want to welcome everyone. We hope to be able to provide you guys with a lot of information, high level, regarding QCDRs and qualified registries. Please feel free to ask questions and answers at the end. I look forward to telling you guys more about QCDRs and qualified registries. So I'm going to go ahead and hand it over to, actually, let me go over the agenda. Sorry, I'm getting ahead of myself. Next slide, please. So this afternoon, we're going to go over the quality payment program overall, just kind of the umbrella of what it is. We're going to go over third-party intermediaries, QCDRs, or qualified clinical data registries, and qualified registries, as well as overview of quality measures, MIPS quality measures, and QCDR measures, QCDR measure requirements and considerations for approval. And as I stated before, we'll also be having a question and answer portion to kind of go over, to give you guys a chance to go over some questions you guys have. So now with that being said, Hector, I'll go ahead and pass it along to you.
Thanks, Sharday.
You're welcome.
All right, so I'll be going over some quality payment program participation information. Next slide. The Medicare Access and CHIP Reauthorization Act of 2015 ended the sustainable growth rate formula, which would have resulted in a significant cut to Medicare payment rates for clinicians. MACRA advances a forward-looking coordinated framework for clinicians to successfully participate in the quality payment program, which is composed of two tracks. One is the Merit-Based Incentive Payment System, or MIPS, and the other one is the Advanced Alternative Payment Models, or Advanced APMs. Our team focuses solely on the MIPS track. Next slide. As mentioned in the previous slide, MIPS is one way to participate in the quality payment program. Under MIPS, CMS evaluates your performance across multiple categories that lead to improved quality and value in our healthcare system. The 4 performance categories are quality, which assesses the quality of care you deliver based on measures of performance; promoting interoperability, which assesses your promotion of patient engagement and electronic exchange of health information using certified electronic health record technology; cost, which assesses the cost of the care you provide based on your Medicare Part B claims; and improvement activities, which assesses your participation in activities that improve clinical practice and support patient engagement. Our contract supports quality, promote interoperability, and improvement activities as CMS calculates the cost performance category. Our team, however, focuses solely on the quality performance category. Next slide. Some information regarding third-party intermediaries. Next slide, please. A qualified clinical data registry, or QCDR, is an entity that demonstrates clinical expertise in medicine and quality measurement development that collect medical or clinical data on behalf of MIPS-eligible clinicians to track patients and diseases and foster improvement in the quality of care provided to patients. Clinicians must be on staff with the organization and lend their clinical expertise in the work carried out with the organization as a QCDR. These organizations may include specialty societies, regional health collaboratives, large health systems, or software vendors working in collaboration with one of these medical entities. QCDRs may submit data and MIPS quality measures, as well as the QCDR measures that are approved for their use. Each QCDR may support up to 30 QCDR measures. Originally introduced within the 2014 Physician Quality Reporting System, the QCDR submission mechanism has been active from the inception of MIPS. For the 2021 MIPS performance period, 58 QCDRs were approved, with 365 unique approved QCDR measures. Next slide. A qualified registry is a data intermediary that collects MIPS data from MIPS-eligible clinicians and submits it to CMS on their behalf. Clinicians work directly with their chosen qualified registries to submit data on the selected measures or activities they have selected. Qualified registries may not support QCDR measures, which is a big distinction between the two entities. Originally introduced within the 2008 Physician Quality Reporting Initiative, the Qualified Registry submission mechanism has been active from the inception of MIPS. For the 2021 MIPS performance year, 124 qualified registries were approved. And now I'll pass it over to Jocelyn.
Thank you, Hector. We'll dive into the quality measures now, so we can go to the next slide. So as Hector was mentioning, that the qualified registries were not, the big distinction was that they could not submit those QCDR measures. This is really looking at sort of how that breakdown exists within MIPS. So qualified registries may support any combination of the MIPS CQMs or MIPS quality measures, and then also the electronic quality measures. Additionally, QCDRs may support a combination of the MIPS measures, the ECQMs, and approved QCDR measures. Any QCDR does have the opportunity to work with other QCDRs to gain permission to submit their measures as well, but that does have to be submitted at the time of self-nomination. So this is the image on the right-hand side of this slide is just really a depiction or an illustration of who can submit what within MIPS. So, and then just uniquely at the bottom is just that QCDR measure is only available for those approved QCDR vendors. Next slide. We wanted to outline the process in which a quality measure can be reported within MIPS. And really there is two ways to be available. First off is the MIPS quality measure side, and then the QCDR side. So first off, we'll run through the MIPS quality measure pathway, and that is looking at, currently there's 209 quality measures for the 2021 performance period. And these go through a longer process. They are submitted to the annual call for quality measures for use by the clinicians, groups, and qualified registries and QCDRs. Any organization is able to submit an unlimited number of measures through the call for measures process. And some years will have hundreds, other years will just have 50. It just depends on the year. After they are evaluated by CMS, if they do If they are placed on the MUC list, they are then evaluated by the Measures Applications Partnership, otherwise known as the MAP. And there are a little bit different requirements between the two measure types, or QCDR versus MIPS. So they have to be fully developed, clinically relevant, evidence-based with adequate reliability, validity, and performance gap information provided during that call for measures process. As I did mention, it does take a little bit longer to get from the call for measures to being implemented within the program. So for a MIPS measure to be implemented, it is approximately a 20-month cycle from start to finish. On the other hand, QCDR measures a little bit faster, and we have a little bit more. Currently, for the 2021 performance year, we have 562 QCDR measures, and they're submitted by QCDRs, and that's limited to the approved QCDRs during the self-nomination. As mentioned, the QCDRs only can submit up to 30 QCDR measures annually for consideration. So each year they are reevaluated. So it doesn't matter if last year they were approved or a couple years ago, they have to be submitted every year. Again, we may have upwards of 1,000 measures to evaluate, or just the least number of amount, I think we were like 600 or 700. So we do see a lot more QCDR measure inventory. Controversially, or they are not evaluated by the MAP, so they are actually evaluated by a number of different clinicians and within CMS following the self-nomination process, but do not go through that MAP review. The major difference, another difference between these two measure types is they must be fully developed, clinically relevant, and evidence-based, but we have a little bit of a different process of testing. So that first year, this upcoming self-nomination, we are just requiring face validity to be completed, and then any subsequent year, it'll be fully tested. So it'll be an incremental approach to testing. So any new measure that first year, it always has to be face valid, and then subsequently fully tested with reliability and validity testing completed at self-nomination. And as I had mentioned, it is an annual process, but it does, it's not that 20-month cycle. They'll be self-nominated in the September of the year or the prior year, and then a few months later, they are ready for implementation. So a little bit quicker of a process. Next slide. This is just really an image to show the different pathways and illustrates, why it takes so much longer to get through into a MIPS process, because there's a few more steps. So going on the left side pathway for a potential quality measure, it would go through the call for measures. If it makes it onto the MUC list, it then goes to the MAP and voted on there. Then CMS will take the MAP feedback into consideration and determine whether it should be proposed. And it would be included in the NPRM, and then stakeholder feedback and comments will be considered and then possibly finalized. And then lastly, available for MIPS reporting. On the right-hand side, it illustrates the QCDR self-nomination, where it follows a little bit quicker pathway, and it's a CMS annual review if the measure is approved or not, and then it is available for QCDR reporting. Next slide. Okay, so the MIPS call for measures timeline, we are currently underway in the call for measures is open, so we'll back it up a little bit to February. Candidate measure submission opens, and then there is a series of tips and tricks and needs and priorities information that's posted on the pre-rulemaking website, and it just allows for MUC stakeholder education and outreach materials to be posted during that March-April timeframe. This year, the call for measures does close on May 27th. So all information would be required to be submitted at that time. And then the months following, CMS and measure SMEs will really take a peek at those measures that were submitted, review any candidate, and then may hold a federal-only stakeholders meeting. In September and November, the CMS and the Department of Health and Human Services, it goes into a clearance process of that draft MUC list. In December, and I know this last year, if you're familiar, we had, just due to everything that's going on in the world, it was delayed, but typically, in a typical year, the MUC list is published no later than December 1st, where we hold the MAP meetings in the December and January timeframe. But again, this year was a little bit unique, as we all can appreciate. And then in February, that is when the MAP recommendations are published, and CMS really takes a look at those to see and helps determine which measures should be included in the proposed rule. Next slide. All right, going over to the QCDR measure self-nomination process. This just sort of outlines a flow of how we evaluate measures. So we do have a process called the QCDR measure review or preview process, and this just is a collaboration between CMS and it is open to any potential QCDR to review QCDR measure concepts. And we are currently holding these, or it's open for requests right now through beginning of June. And what we do is just we request that measure concepts are provided to the team so that we can evaluate them and make sure and provide any feedback that might be meaningful. So is it a gap in the program, or maybe it's duplicative, things like that, just so you don't go down an avenue not wasting resources, but developing a measure, but it's already in existence. So try to do that, and those have been proven to be very successful. As I said, submit QCDR measure review. QCDRs will submit up to 30 QCDR measures for CMS review. And then once approved, that's when the specification process occurs. So we would collaborate with CMS or the QCDR and get those ready for posting on the QPP resource library. And then QCDR measure submission, submit the QCDR measure performance data for any of those eligible clinicians or groups, and that occurs just following the close of the performance period, January through March. And then on the off season of all of that, we do continuous evaluation, see how the measure's being used, and just maintenance process. And we assess those QCDRs performance and data, and really to see if the measure is meaningful and there's adoption, things of that nature. So that in a nutshell is the QCDR measure and self-nomination process. Next slide. With that, I will send it on over to Marla to go over QCDR measure requirements and considerations.
Thanks, Jocelyn. So next slide, yes. So some of this will be a little bit redundant because you can't really speak about the QCDR measure self-nomination process and the timeline without talking about the measures, but I think this will be good information for you to have. The benefit of a QCDR measure is that they are more agile to implement than MIPS quality measures, and you already saw that through that timeline, the pathway, where one side was very long and the other side was short. QCDR measure revisions can be completed to reflect the latest clinical guidelines without going through rulemaking. Also, the preview calls, as mentioned, CMS will collaborate directly with the QCDR to go over suggestions to refine and create meaningful measures. The rapid development and innovative measures for MIPS is definitely a benefit. QCDR measures may address clinical topic or epidemic, such as our current public health emergency, without going through the 20-month call for measures process. It also gives CMS an opportunity to see the QCDR measures and then see their potential as a MIPS measure and request that those be submitted to the call for measures process. CMS is also able to review measure testing data to complete a comprehensive evaluation of potential measures. Also, and this is at the heart of the QCDRs, is that this is the opportunity for specialty specific or subspecialty specific QCR measures to be available to the eligible clinicians that are participating in the MIPS program. Next slide, please. So QCR measure requirements. The QCR measure should be beyond the measure concept phase of development. They need to address significant variation in performance. They need to be in alignment with the incremental policy stated in the new final rule, and that is in regards to testing. Need to address areas of duplication. And this is one of the things that we really recommend, that even before the measures ever put forth into self-nomination, is that a thorough environmental scan of current MIPS and QCR measures are considered before you write the new measure. That also applies to retired MIPS and QCR measures that might have been topped out or retired for some other reason. They need to align with current clinical guidelines, and then, as well as this year, like we discussed, we'll need to ensure face validity. Next slide, please. CMS will also include the following considerations for approval of the QCR measure. Prefer outcome-based rather than the clinical process measure whenever possible. Want to address patient safety and adverse events. Identify appropriate use of diagnosis and therapeutics. Address the domain of care coordination, as well as the domains for patient and caregiver experience, and also pay attention to the areas of efficiency, cost, and resource use. Next slide, please. So these are just a couple of additional considerations. One is that the QCR measure must be owned or by an approved active QCDR. An approved active QCR has undergone the self-nomination process where they become approved, which means that they have met certain requirements such as measure expertise, clinical expertise. So if for some reason the QCR is no longer going to remain in the program, the measure can, though, remain in the program if ownership is transferred to another owner. And also you can borrow another QCR's measure, but proof of permission must be granted and confirmed at the time of self-nomination. That does have to be written permission, showing that the other QCR that owns the measure is allowing the borrowing QCDR to self-nominate that measure. So QCR measures must provide proof that there's room for quality improvement. Performance data should be submitted with the self-nomination that supports evidence of a performance gap. And this is a new requirement for the 2022 performance period, that data has to be collected. QCRs are required, I got ahead of myself. So QCRs are required to collect data prior to the submission of the QCR measure for CMS consideration. Again, that is for 2022. The measure needs to be attributed to the eligible clinician. And the actual QCDR organization's systems must be implemented and able to accept data should a clinician, group, or virtual group wish to submit data on any of those approved MIPS quality measures and QCR measures by January 1 of the given performance period in which it was approved. Next slide, please. Just a few resources that we can provide and point you to learn more about QCDRs and the MIPS Quality Payment Program. Here's a list of links, and with the slide deck being made available, these are different ones that you can access. Next slide, please. This is the link to the 2021 Physician Fee Schedule Final Rule. You know, we've already talked about rulemaking process, and the third-party intermediary section is where you can find information about the qualified registries and QCDRs. Next slide, please. If you do have questions, please contact the Quality Payment Program Service Center, either by phone or email. There is a hint to call during non-peak hours, which is before 10 a.m. and after 2 p.m. Eastern Time. There's also an accommodation for those that are hearing impaired, that you can have access to a TRS communications assistant. Emails must be sent directly to the qpp@cms.hhs.gov in the to line of your email. If you forward the email or you CC the email, this does not trigger the creation of that case number for your inquiry, which therefore means that it won't be tracked and you may not get the answer that you need in a timely manner. Next slide, please. We'll now open the question and answer session. Thank you.
Thank you all so much. We have gotten quite a few questions in the chat and in the Q&A feature, so I will just jump us in. The first one is, if you could please just repeat what the difference is between qualified registries and QCDRs.
Sure, sorry about that. Getting off double mute. So the biggest difference between the two is that QCDRs can, submit QCDR measures for CMS consideration. So they can support MIPS quality measures as well as QCDR measures. Qualified registries can only support MIPS quality measures. And that's really the biggest difference. The other difference is, like I mentioned or went through in one of my slides, I believe it's slide 11, the QCDRs have a higher threshold or higher bar in terms of criteria that they need to meet in terms of measure development and things like that due to, again, the ability to submit QCDR measures for CMS consideration.
Perfect. Thank you, Hector. We got another question. How long before a QCDR measure without a benchmark is targeted for removal?
I can take that one quick. So after 2 years of going through the submission process and not receiving that benchmark, we do allow an opportunity for QCDRs to submit a participation plan, just outlining how they're going to increase adoption, whether it be creating a broader patient population, making sure that it's appropriate, of course, or perhaps they make it a contingency if you're going to report through that QCDR that you have to submit that measure. Things like that, just to increase adoption and making sure that those QCDR measures are meaningful to the clinicians that use them. So long answer, 2 years, but then that additional opportunity for participation plan so we can monitor how that impacts adoption.
Great, thank you so much. Let's see, one of our participants represents an advanced APM and wants to know where they might be able to find any webinars or other resources on the reporting of quality via registries that they have to use for quality reporting in 2022.
Yep, I'm not as familiar with resources for APMs. I do know there is a Quality Payment Program webinars website. That might be helpful in potentially finding webinars or resources pertaining to advanced APM. I believe, and Josh, correct me if I'm wrong, I think it's Quality Measure 047 that needs to be submitted if it's an APM that wants to submit, right?
Yep, I believe so.
Okay.
Awesome, thank you. We also have a request from the audience about where they might be able to find the list of retired QCDR measures.
We don't have a list of retired QCDRs per se, or QCDR measures per se. And honestly, just thinking through this of the logistics, I think it's important to keep in mind there may be QCDR measures that we may have retired, but it's not because they're low bar or that they're topped out or lack adoption. It may just be that the QCDR no longer was going to participate. We've had a QCDR in the past take a year off. So it wouldn't say that they're retired in a sense of the typical rationale for retiring. So I know we don't have that, but it is year by year, the QCDR measures are posted on the QPP resource library. So if it's not there in a subsequent year, then that would indicate it's retired, but that does not provide the rationale for why it's been retired, much like it would in the as the MIPS measures that we provide a rationale within the rule.
Thanks so much for that context. We've gotten a couple of questions about whether or not registries can submit ECQMs and whether or not there is either a specific approval type for those, or if the registries need to be certified to submit ECQMs. Anything you can tell us about that process?
Sure. So registries and QCDRs can both submit the ECQMs. Those are considered part of the MIPS quality measures. So if there is a clinical quality measure that has an ECQM equivalent, those can be submitted. The way that the registries or QCDRs go about that is during the self-nomination process that was mentioned during the call. There is a tab that they can let us know which clinical quality measures and/or MIPS ECQMs they want to support, and it's part of our review and approval process. And again, they submit that information during the self-nomination process to our team for review.
Great, thank you very much. We had a question about whether or not CMS or any other agency provides any funding to support QCDRs.
Good question. No, we don't. I don't know of any anybody to provide that funding. I'll take it back to Dr. Green just to confirm, because I am a little new, but no, I'm not aware of any funding.
Thank you for that. Let's see, we also have a participant from a retina specialty that submits MIPS measures through the IRIS registry. Are there QCDRs qualified for submission for MIPS quality measures?
I'm trying to, where is that question? Could you repeat it? The IRIS, and they're asking if there's additional MIPS measures?
It looks like they're asking whether there are QCDRs qualified for submission for additional MIPS quality measures, but the wording in the question.
Yeah, I'm sorry, I'm not fully understanding the question, so if they can provide additional clarification. I do know IRIS is a QCDR as, and I want to say they're also a QCDR or a qualified registry, but I do know that they have some specialty-specific IRIS QCDR measures as well as MIPS. So I hope that answers your question, but if not, if you could add some context, I'll be happy to take another go at it.
Sure thing. I'll keep an eye on the chat in case we get follow up on that. But in the meantime, we have a question from another guest. In the list of qualified registries, they notice that some have a note about CMS remedial action. What impact does that have on organizations that are using those qualified registries for MIPS reporting?
This is a great segue. So I just want to add to the previous question. I know we asked for clarification, but a good place to also look to see what measures an approved qualified register QCDR can support for the given performance period is our qualified posting. That's available on the QPP resource library, and you'll be able to find that information there. So in terms of the remedial action notation on the qualified posting, it does not have an impact on any clients that the qualified registry or QCDR may have in terms of the ability to submit data. The only time that it would impact any clinicians groups, virtual groups, APM entities or anything like that would be if that entity was terminated from the actual MIPS program.
Perfect. Thanks, Hector. Okay, I'll just give folks a couple more seconds to see if there are additional questions because we've gotten through all of the ones that I have. Let's see. Oh, I'm sorry. We did get clarification on that IRIS question. So IRIS already tracks the QCDR now. I'm wondering if those QCDRs are eligible to report as quality measures.
I was just going to say it may be helpful, as Hector was just mentioning the qualified posting, it really shows which measures they are eligible or they can submit. So it could be a combination between MIPS quality measures as well as QCDR measures. It just depends on, during that self-nomination period, what they selected.
Yeah, and I would just clarify that QCDR measures are considered as part of the six quality measures that clinician groups, roadshow groups have to report. So the QCDR measures fall under the quality measures as well. So with the QCDRs, they would be in addition to the MIPS quality measures, which again include the clinical quality measures and the ECQMs. I don't know if that helps clarify, but again, the qualified posting does have that information, and we'd be more than happy to answer the question via email as well.
Perfect. Thank you both for adding those contours, and we'll follow up with that participant afterwards if there is additional questions to be answered there. We also got a question about, under what circumstances would a QCDR be subject to the new information blocking rule?
I am not quite sure. That's a policy question. That one might be something that might be outside of our scope. We don't quite, when we look at or when we vet the registries and QCDRs, it's not something that we look into. But we can, if that question is submitted through the QPP help desk, I think might be appropriate so that it gets to the appropriate subject matter expert.
That sounds great. Thank you. Yeah, I will say we've also gotten a handful, just a couple of other questions that are great questions, but are a little bit out of scope. So I think those we're going to refer to separately, just so as not to derail the conversation here, but did want to acknowledge that we have seen those questions, and we'll get those referred to. So I think with that, we have reached the end of the other questions that we had in the Q&A. I wanted to once again thank our presenters today for this informative discussion, and to thank our participants for all of the great questions and for their engagement in the topic. So just very quickly, can we just jump to the next slide? Just wanted to let everyone here know that we do have another information session coming up in May. That one is going to be on measure specification. So how to actually create very clear and unambiguous measure specifications, which might be of interest to anybody who is new to measure development or who just wants to know what goes into that process. And then in case you missed last month's info session on patient-reported outcomes that we did in alongside NQF, that presentation is now available on the CMS YouTube page, and when we post these slides, that link will be active, so you can click on it there. Next slide. All right, and with that, we will let you all go. Thank you again so very much, and we will talk to you all next month. Have a good one.